treating high-risk multiple myeloma is complicated because we know that these patients are very likely to relapse early after their frontline treatment and be resistant to subsequent lines of therapy. However, we know that in randomized clinical trials that high-risk patients do respond well to various multi-agent combinations, including monoclonal antibody combinations such as DRD or DVD in the second line if they've not previously received monoclonal antibody. We know that patients with high-risk multiple myeloma also respond well to novel agents such as CELMoDs if they are refractory to prior IMiDs. I think for patients who are high risk and have also manifested that early relapse after initial therapy, which often includes stem cell transplantation, then I think you want to offer the patient a novel therapy, especially if they're triple class refractory to a PI-IMiD and monoclonal antibody. And that might be a clinical trial which involves using a CAR T-cell therapy in earlier lines of therapy, since high-risk patients seem to respond to CAR T-cell therapy well, or a bispecific antibody combination therapy would also be very reasonable for a clinical trial in these high-risk patients. There are clinical trials that have looked at initial therapy for high-risk multiple myeloma that use 4 or even 5 drug combinations, and those are promising. But in the relapse refractory setting, it's really essential to enroll patients with high-risk myeloma in clinical trials and offer triplet or quadruplet therapies as outside of a clinical trial standard of care.